Okay, into part B for chapter 19. This one's going to focus primarily on bipolar disorder. Bipolar disorder is a spectrum of disorders that are most importantly characterized by wide divergence and rapidity of emotion changes from high highs to low lows. As always, there's a spectrum there, higher highs and lower lows. The issue is that it's going to be chronic. It can be progressive in some cases if not treated properly, and especially the low lows can result in potentially life-threatening depression, or in some cases on the other side of the equation, inappropriate risk-taking, inappropriate dangerous types of behaviors due to overconfidence. Here are just a few examples of what we would consider potential symptoms for high highs and low lows. The two poles, and what we see is a shifting between them, sometimes quite rapidly. It's a very, very significant disorder. We're talking on the order of 10 million people in the United States alone that have probably some form diagnosis of some kind. 83, so roughly 8.5 million of those have severe symptoms. There are different forms. It is a spectrum, and the typical age of diagnosis is actually well into what we consider adulthood. Bipolar disorder is one of those diseases that illustrates well one of the barriers to therapy, which is agreement and consensus on what comprises the disease and how the disease is manifested. At this point, we have four major categories. Again, this is a human convention on a spectrum of disorders. So sometimes there are a few, square pegs and round holes, if you know what I mean. The way that they categorize these things are based on the mood state and the duration of those and frequency of those mood states. And it has to do back to the different types of neurotransmitters that involve what piano chord the brain is playing in terms of activated neural pathways. So we know that bipolar disorder typically starts in the mid-20s. I put 25 here, but it can range anywhere from 20 to so forth. You can see it earlier, and you can even see it later. It can come on suddenly due to stress, what we call hypothalamic type disorder, and we'll talk about that a little bit later. Usually there's some sort of medical cause if we see a late onset of symptoms. That's usually something else that's driving that. And most often when we have bipolar, we'll see anxiety, addictive behaviors, including eating and substance abuse. What we know about the causes, we know there's a genetic component, and I'll show you some evidence on the next slide. Environmental factors, this has to do with stress, with activation of cortisol pathways, and again, I'll have some more on that. And then the neurotransmitters that are involved. If we have an imbalance of neurotransmitters, that can contribute to the disorder that may be genetically or environmentally triggered with those neurotransmitters. The evidence for genetic predisposition to bipolar disorder is as strong as almost any neurological disease. In fact, it's approaching what we would call the ideal Mendelian percentage. I'm not going to break that out too much. For instance, and this is probably one of the strongest things, if you have a parent with bipolar disorder, you have a 50% risk. That's pretty strong evidence for a dominant type phenotype. There's certainly multiple genes involved, but there seems to be some aspect of this that implies an autosomal dominant situation. Environmentally, If you have, let's say you have a few minor genes associated with bipolar, but they really don't manifest all that much. If you experience some sort of environmental stress, this can be emotional stress, it could be occupational stress, a traumatic event. Post-traumatic stress disorder triggers a lot of this sort of bipolar disorder. We're observing that in many veterans. Um, but what seems to be going on is that this hypothalamus pituitary adrenal axis is kicking in, and that's leading to imbalances and so forth in the four big ones: norepinephrine, dopamine, serotonin, and glutamate. The four amigos that we've been talking about repetitively over the last couple of weeks. And so this is the HPA axis, the hypothalamus, anterior pituitary, adrenal cortex. What happens is some stimulus, some initiating stimulus triggers the hypothalamus: stress, injury, emotional input that then causes the hypothalamus to release a trophic hormone that diffuses to the anterior pituitary, and it stimulates certain cells, adrenocorticotrope cells. There's about 5 or 6 different cell populations here, and it stimulates one of them to release a hormone called ACTH that then diffuses to the adrenal cortex, releasing cortisol and adrenaline, or epinephrine, and some other stress hormones. When we have overstimulation of this, we call that hypercortisolism. And initially, it's meant to feedback. We're supposed to alleviate that stress. But if we don't see alleviation for whatever reason, this can become maladaptive. So the neurochemistry is the usual suspects, serotonin, norepinephrine, dopamine, and glutamate. These are kind of the big four. Again, the chord that we play with these dictates what type of mood that we feel. Um, I'm going to address this now, but this is actually a larger hypothesis for any number of the neurocognitive disorders that we've seen. This idea of what we call the kindling hypothesis. Kindling is the material that you would use to start a fire. So you start with small sticks and you get those burning a little bit, and those burn enough to light the large sticks on fire, if you will. Have you ever heard that phrase, the straw that broke the camel's back? Well, that's a form of kindling hypothesis, only it's situational rather than, shall we say, medical. And that's partly what drives this idea of stabilizing the mood, stabilizing not only pharmacologically, but also stabilizing through non-pharmacological interventions. So we try to get people to cognitively break a mood reinforcing cycle, cognitively get themselves out of situations that may trigger departures from homeostasis in a neurocognitive way. And it gets back to the idea of trying to dial down whatever influence this stress axis is, the stress axis. So we have hypothalamus, whatever's triggering that, we want to eliminate that trigger. Because when this goes off, it fires off the anterior pituitary and the adrenal cortex. Now we've got epinephrine, now we've got cortisol, we've got stress hormones, and it's then feeding back to imbalance the neurotransmitters. With the bipolar, the negative feedback cycle doesn't seem to be as functional as it could be or should be. But we can see this in any number of ways. This is partly why we see elevated levels of bipolar in people coming back from military duty. We see elevated levels of bipolar in people who are chronically abused, either by spouses or relatives, in any number of ways. It doesn't have to be sexual. It can be psychological. It can be physical. What happens is we start off with recurrent stress that may lead to minor behavioral adaptations, but as it goes, it reinforces into major manifestations and can become spontaneous, absent. So someone who's experienced repetitive stress in particular may go into episodes even though that stress has been resolved, that failure of negative feedback, if you will. With the four amigos, if you will, glutamate, norepinephrine, dopamine, and serotonin, what we see is an imbalance. That is to say, the cholinergic stuff, the parasympathetic, versus the catecholaminergic, the sympathetic. These are just different words for the same things we've already been talking about. So it's a sympathetic, parasympathetic type imbalance, specifically in the brain, less so in the peripheral tissues. But so there's an imbalance there. And more recently, and this is really, really interesting to me, I don't know enough about it to really talk, but there seems to be some issue with this sugar of all things. It's a type of sugar. It's called inositol. Inositol is often linked to phospholipids. So what we see are these phospholipids, and instead of a phosphate there, they have a sugar, and so it's part of the cell membrane. That's really, really cool because it implies a biophysical disturbance, and that's neat. I think that's really cool. So that's coming up, and so hopefully we're gonna make some inroads in that direction. In addition to the inositol sugar story, there seems to also be a role for glial cells, oligodendrocytes, which make myelin, microglia, and astrocytes. That's one of the primary glial cells. It's not just bipolar, though there seems to be a stronger connection in bipolar at this point than other disorders, but it's very, very interesting, and additional therapies in the future will be hopefully arising. Here is some specific evidence that links glial cell issues with bipolar disorder. When we look at glial cell density in biopsies of bipolar versus normal control populations, we see a significant diminishment of glial cell density. So there does seem to be some role, perhaps it's a glial degeneration, if you will, rather than a neurodegeneration. With bipolar disorder, we have a holistic approach. We're not only going to use drugs, things like mood stabilizers, in particular lithium and valproate sodium. We can also go after it with drugs that are designed to lower overall neurologic activity. And we've talked about carbamazepine and gabapentin in other situations. We're going to talk about lamotrigine, one of the harder drugs to pronounce, I'll be honest with you. We're going to go over that mechanism a little bit. Above and beyond pharmacology, we have cognitive brain therapy and other types of psychotherapies. Again, trying to help avoid behaviors which trigger bipolar epissodes. Somatic therapies, things like light therapy, seasonal affective disorder falls under this category, a form of transient depression and so forth. Lots of possibilities, again, trying to avoid the high highs and the low lows. And we've talked about some of these antipsychotics in previous lectures. But we're going to focus on lithium valproate and lamotrigine for this disorder as our poster child drugs. Lithium, a really, really interesting drug for dealing with bipolar. So prevalent and so common in its prescribed use that Sirius satellite radio actually has its own channel called Lithium, going after sort of a 1990s, 2000s era alternative rock music. We know that it has a number of effects. Its true therapeutic mechanism is not entirely clear. I guess it's probably a combination of small effects in various directions. What do we know about it, or what do we believe is going on? It seems to increase serotonin, so it's increasing the sort of the neurotransmitter that's associated with positive thinking. On the other hand, it's also involved in what we call second messenger systems. And I'm going to just, in a nutshell, some of you know what a second messenger is, but this gets at something I've talked about earlier. When we have a receptor that's activated, one of the types of enzymes out there is an enzyme that will cleave phospholipids. So we have these phospholipids, and they have the phosphate head group, and then they have the lipid tail. That phosphate head group can be cleaved off and become a second messenger. So it activates this enzyme. We have the fatty acid group called diacylglycerol. It's a mouthful. That's just the fatty acid tails of a phospholipid. The head group, this thing right here, IP3, specifically inositol 3-phosphate. So it's got 3 phosphates on it, can serve as a second message. What lithium seems to do is lithium seems to block the recycling of that inositol head group. And for reasons we don't fully understand, lithium slows that down. Maybe it prevents more of this from being created in the first place. Maybe there's a toxic effect. If you have too much of this, you have too much inositol, that may be a problem. But that inositol system is blocked in lithium. It's really, really interesting. So we don't really know, but increased serotonin, decreased second message, maybe a sort of a neurosuppressant of some kind, or a cell response suppressant of some kind. Don't really know. Here's the sort of wordy side of this. Take the words here. Diacylglycerols are the fatty acid tails in a phospholipid. The head group, one kind of head group, is an inositol head group. That becomes a second message on its own. So it seems to be blocking that for some reason. In terms of adverse effects of lithium, biggest thing is that it makes you want to pee. It's probably competing with things like sodium, because lithium is a monovalent cation. It resembles sodium to a certain degree. Even though we think of serotonin being involved, nevertheless, it's probably getting after dopamine as well. Why we might see a hand tremor there. Headache and concentration, that could either be blood flow or could be just the neurosuppressant activity of the lithium. Is a risk of some nephrotoxicity. What we call diabetes insipidus. This is where you're not able to retain water. That's probably involved in that polydipsia, polyuria. You're losing water more rapidly, and so you need to drink a lot of water. It's not the same as diabetes mellitus. People will mistake that sometimes. This is too much peeing and needing a huge amount of water. You keep a lot of thirst. I knew a guy with diabetes insipidus, and that guy could down 6 or 7 drinks at lunch easily. It also does seem to have some ability to trigger goiter. So these are sort of the common side effects of lithium that we want to watch out for. Sodium valproate, another drug that's commonly used in bipolar. This is like an acetylcholinesterase inhibitor. It's inhibiting an enzyme that breaks down GABA called GABA transaminase. So less activity of transaminase in the synapse means more GABA sticks around longer. Longer half-life reduces neuronal firing because GABA receptors cause hyperpolarization of the downstream cells. When you hyperpolarize, you have fewer action potentials, and so you are reducing neuronal activity. The side effects of sodium valproate, most of them are relatively rare. You occasionally get some cosmetic issues, some metabolic issues. Occasionally, somebody will have issues with, especially folks who have alcoholism. You may see an exacerbation of hepatotoxicity secondary to their alcoholism. That may also be linked to some of why we see immunosuppression or pancreatitis. The big one, probably the most important one, is that valproate is a teratogen. It will induce birth defects. Oftentimes, the health providers and drug safety organizations strongly recommend for women in their reproductive years, that if they are going to take sodium valproate, that they are actively involved in a pregnancy prevention program, uh, taking contraceptives in particular, because we know that contraceptives do not interfere with valproate, and valproate does not diminish the efficacy of contraceptives. There are no known drug interactions between contraceptives and sodium valproate, but the risk is really, really high for birth defects, even higher than other anti-epileptic drugs, which have similar warnings. So it is strongly recommended that for effective treatment. Bipolar is a life-threatening disorder. We wouldn't want to deny care, but we also have to be in mind of effects on others, particularly unborn children. The lamotrigine mechanism of action centers around the release of excitatory neurotransmitters glutamate and also aspartate. In order to get that release, you have to have sodium flux, and the lamotrigine seems to be able to dial that down. So it's blocking the release of these excitatory neurotransmitters. We see this not only in bipolar, but we also see this in epilepsy. So lamotrigine is used in epilepsy in addition to bipolar. It's dialing down neural activity. So what we do is we block that sodium influx, we block that depolarization, we have less neurotransmitter release, and no excessive stimulation of the pathways that we're interested in. In that way, lamotrigine and to a certain extent valproate sodium are all working on the same voltage-gated sodium channel. Carbamazepine and dilantin, phenytoin, also can affect those channels. By blocking sodium flux, you have fewer incidences of release of neurotransmitter, particular glutamate and aspartate. One of the great hopes when it comes to bipolar and other types of mood affective disorders is that while they are chronic, they are not necessarily progressive. They can be managed, and that's the goal here, is to stave off the possibility of worsening symptoms. It's not necessarily progressive, but it will progress if the stimulus is not dealt with, if the causality is not dealt with. So first line drug is lithium. It's a mood stabilizer, and it's used in all three phases, if you will, sort of general phases, the mania, the depression, or this sort of cycling back and forth. When it comes to mania, we might add an antipsychotic, sort of like with schizophrenia. With depression, we can do the same thing, but we may add an antidepressant, so like an SSRI. If we have this rapid cycling, that may mean the valproate or the lamotrigine. So you can kind of see how this works, and how this might help you is to understand where the patient might be in this spectrum, to help you understand what they may be going through. So this concludes our lecture on bipolar. As always, get to know the symptoms, get to know the signs, understand the pharmacotherapy, what we're trying to achieve, and why we might be prescribing it at a certain time. As always, if you have questions, just let me know. Bipolar is very, very common. We've had students come through our program with bipolar. It is treatable, and it is not worthy of some of the social stigma that gets ascribed to it. So if you feel like you know somebody, or you yourself could use some assistance, that the important thing is to talk to somebody about it. Thanks for your time, and I will talk to you soon in chapter 14.